Hi, Chad Higgy. I'm a flight paramedic at STARS in Calgary, and I'm also a clinical educator. I'm joined on the phone by Dr. Gavin Greenfield.
Hi everybody, it's Gavin Greenfield. I'm one of the transport physicians out of the Calgary base and the medical director of education for STARS.
Okay, great. And so the reason that we're here today is we're recording, the screencast to complement the CCMCPs. The CCMCPs specifically for mechanical ventilation. There's been a significant change to them, and they've been updated kind of in response. Well, I guess the protocols themselves have been built over the last 8 or 9 months. We've pushed them out in response to this COVID situation, and we're playing some catch-up education here right now. And so we're going to have a series of these screencasts that are going to cover all the protocols, all the nuances, and we'll try to keep them short and digestible. We'll make them a bit interactive, and if you have any comments or questions, we can certainly take those by leaving an email at the end. And so what I'm navigating on my desktop the protocols, and we're going to go into those in a second. And if you can download the app, obviously, and if you were just had your on a desktop or whatever, then you could Google AHS, EMS, CCMCPs or MCPs, and they'll come up, and you're going to find yourself to the same screen. And so if I click on the critical care MCPs, and I follow this over to respiratory, at the bottom of this next section is mechanical ventilation, and then we go up and we get to universal, and this universal protocol is essentially where you're going to go to find out where you should go to get the information that you're going to need in order to ventilate the patients that you currently have in front of you. So there's 4 that we're going to really concentrate at the very end: obstructive metabolic acidosis, brain injury, and the normal restrictive protocol. Prior to that, there's a couple of other ones that I just wanted to touch on here. So one is, patients less than 30 kilos. So those are children. If you're under 30 kilos, you need some specialized equipment, specialized knowledge, and so in the notes we cover that. Patients in cardiac arrest, we can use a ventilator on these patients for sure, but you need to be really facile, really familiar with the ventilator. And so in order to do that, you just need to have some experience, and there's some notes there on specific settings, etc. And if you're non-invasive ventilation, then we got this whole section on initial settings, how to make initial titrations, but those aren't going to apply to the patients that we're going to be talking about in either of these next few protocols, which is patients with obstructive lung disease, metabolic acidosis, brain injury, or the normal restrictive. Gavin, let's just start us off here with this obstructive lung disease. What do we, those patients that end up in this area, how do they end up there?
Sure. So how they end up here is we've got a patient in front of us that needs to be mechanically ventilated. They're not a kid. They're not in cardiac arrest, and they're intubated, so we're not going to do non-invasive ventilation. So the first branch point, the way we've laid this out, is do they have an acute presentation of obstructive lung disease? So do they have an acute asthmatic attack? Do they have an acute COPD exacerbation? And the reason I'm saying acute is because somebody could have one of those conditions on their past medical history, but if it's not currently active and it's not the reason they're getting intubated, then they wouldn't necessarily fall on this protocol. Some objective things that can be seen to help you determine if the patient has obstructive pathology are things like the shape of the end-tidal CO2 waveform. So the gradually continuing upsloping shape, we refer to that as a shark fin pattern. Higher inspiratory resistance, higher expiratory resistance, and the presence of autopeep. Those are all things that you can determine from the waveforms on your ventilator. So if the patient presents with that presentation, then they would start here. This is where you would initiate their ventilation. And for all 4 of these final protocols, they all have their own protocol. So the Universal's job is to get you on the right protocol. If it's obstructive lung disease, you're going to back out, and then you're going to go to the obstructive lung protocol.
Okay, that's perfect, and I like how you emphasize that an acute presentation. Sometimes I think we get confused, or if we get, if we're told that this patient has a past history, we might be tempted to go here. But you're saying only acute presentation, only patients that are actively displaying signs of, essentially obstructive pathology, expiratory resistance. Is that right?
Yes, that's what we're saying.
Okay, awesome. Next is metabolic acidosis protocol. There's significant changes in the protocols as to which patients get applied into this protocol. Can you talk about that a bit?
Yeah, so traditionally this protocol in the last version, I mean, who this protocol is meant for is the patient with DKA, diabetic ketoacidosis, or a toxic alcohol ingestion. The way this protocol was laid out previously, however, anyone below a set pH, and on the prior version of the protocol, it was even higher, it was 7.2. Anyone below that pH of 7.2, regardless of how they got there, as long as it's a metabolic cause, so they've got a low bicarb, they would go into this protocol. And the thing that I think we've improved with this version is this third point. So patients with pre-existing shock and metabolic acidosis are often more appropriately classified into the normal lung and restrictive lung protocol. So let me give you an example. So in this metabolic acidosis protocol, of course, the rate is 30. That's a high rate. That's going to increase your mean intrathoracic pressure, and we know that higher intrathoracic pressures have negative hemodynamic consequences. So let's take a patient with hemorrhagic shock, for example. They've got a big pelvic bleed. They're got a blood pressure of, let's say, 75 systolic. If we go, of course, that patient's going to have high lactate. They've got impaired tissue perfusion, and they may easily have an acidemic state and have a pH of less than 7.1 very easily. We've all seen patients like that. Putting that patient onto this protocol is potentially hazardous. So that rate of 30, subsequent increased intrathoracic pressure, as we all know, is going to markedly impair, or potentially markedly impair, right ventricular filling and ultimately impair cardiac output. And that blood pressure of 75 could potentially be made worse. So that kind of patient population is who we're trying to capture in this version of the protocols. And we're saying that that particular type of patient may be better served on the normal lung and restrictive lung protocol.
Yeah, fair. And I know that personally, this has been, this whole process has changed my approach significantly, and I think that I, had a tendency to put those patients in there that were in shock or in and out of cardiac arrest into that protocol, and I think that was an error on my part. I think a lot of those patients may have done better if we just would have ventilated them with a more normal, slower ventilation rate, allowing, preload, not messing with their physiology too much, so to speak.
Yeah, and your example of an arrested patient, I think that kind of illustrates the point as well. So in this case, I think ACLS probably has it correct. What does ACLS tell us to vent this patient that's in and out of arrest? They tell us to vent the patient at 10 to 12 a minute. So, that's more in line with our normal lung and restrictive lung protocol. And ACLS does not tell us to vent that patient at a rate of 30. And I think it's because of the reasons we just discussed.
Yeah, that it seems to make a lot of sense to me. So that's good. The brain injury protocol, that protocol in itself is focuses a lot on CO2. What what for what reason? What do you think? What was the history there, Gavin? Can you remind us?
Yeah, so of course, we know that this patient population does not do well with episodes of hypoxemia or hypotension. So those two things are our first priorities. Once we have those things managed and we're comfortable, the protocol turns to managing CO2. We think that arterial CO2 values are important in the outcome of these patients. So yeah, exactly. It does address how to manage that arterial CO2, and it addresses how to manage the arterial CO2 in the absence of having that value. So, Chad, maybe you can speak a little bit to the concept of bracketing, maybe just briefly, because we will definitely go into it in detail when we review this protocol.
Yeah, bracketing is essentially just using the end-tidal CO2 and the venous CO2 to on as bookends to bracket the arterial CO2, a way of estimating it. And I know we'll talk about this more on the brain injury protocol, but we've used the idea of bracketing to just make a better guess. I think that when you just use end-tidal CO2, you have a tendency to probably underestimate the CO2 levels, and using venous, the arterial CO2 that is, and venous sometimes overestimates it. And so we'll talk about more detail when we talk about that protocol in specific. Let's talk about the normal restrictive lung protocol now.
Yeah, so this is the protocol that we think the majority of our patients with COVID-19 are going to fall into. We use the word restrictive lung to refer to patients with decreased compliance. Now, the reason it's normal lung and restrictive lung is because it's set up identically. So if you are intubating a patient with an overdose, for example, and you intubated them for airway protection only, and they've got nothing else going on, they're hemodynamically stable, the way you ventilate that patient would be the normal lung protocol, which just happens to be the same as the restrictive lung protocol. We're going to focus on the word restrictive because, again, that's, I think, going to apply to our patients with COVID-19. So the term restrictive refers to patients with decreased lung compliance or decreased chest wall compliance. So compliance being, how much pressure do I have to put in there to open up the lung? And these patients, because of their presentation with ARDS, have lower lung compliance and often require higher pressures to open up that lung. So again, I think that's probably where most of our patients with COVID-19 are going to land, is in this protocol.
And specifically, that also helps you troubleshoot. The protocol talks about how to troubleshoot decreased compliance and how to recognize it with the inspiratory flow, troubleshoot the decreased lung compliance, and then some strategies for addressing the refractory hypoxemia.
Yes, exactly. And we're going to delve into this protocol. In fact, that's going to be our next task. We will go through all of these protocols and create separate screencasts for each of them, but we'll go into detail in this protocol in a very short order in the next subsequent screencast.
Gavin, I just brought up the notes, and in the notes, inside the notes, I know you can't see my screen. We talk about a bit on background, some general strategies that I'm going to talk about here in a second. But we elaborate a lot on the classifications there as well, and then as well as when to contact the transport physician. Any comments there as to when you want crews to touch base with you guys?
It's pretty laid out in the algorithms, but as the crew knows, I mean, we want to hear about all these calls, but we also understand if things are hairy and you don't have time to make a call, that's certainly understandable. So at the very end of the notes are some specific recommendations about when we want to hear from you guys, and certainly embedded within the algorithms themselves are some specific times or points when you could consider contacting the TP.
Yeah. Okay. Excellent. And one thing I just wanted to finish on, and this is something that we talk about throughout most of the protocols, is the information you can get from the inspiratory flow waveform. And so we have a couple of examples here under point number 3, which is what to do in response to high airway pressures. And so in this first image, flow gets to 0 inside the inspiratory time. The second image is quite different. Flow does not get to 0 inside the inspiratory image. And so I'm going to do a specific screencast on compliance and resistance, but this information can be quite useful when you troubleshoot high peak inspiratory pressures. In the first image, peak equals plateau, so we don't need to increase the peak limitation if we're come up against it in order to get the breath in, because we know peak equals plateau. In the second image, peak is more than plateau, and we can tell that by the inspiratory flow. Again, really useful information when you're trying to figure out what to do when you've come up against that peak inspiratory pressure limitation. Again, we can't really talk about it we can't really get into the meat of it right now if you don't appreciate that. But under the modes and troubleshooting section of the notes, there's some strategies there, and again, we're going to do a separate screencast on this exact topic. So I think that's all that we have for you right now, and like I said, more information to come. Gavin, anything to finish off on?
No, thanks very much, everybody, and we'll talk soon.
Okay, thank you.